Is it in pediatric clinics? Oh, needs medication?
If we were in clinical,
Ni Alex va a leer el manual. Also, no me acuerdo de qué se me dijo. What did you say?
no, I was like, I was in clinicals and I was trying to figure out how to talk to a kid and I was like,
I remember during the LPN lab, I asked the kid, he was like less than 5, and I asked him if he had allergies. And so the lady that was watching us went and whispered in your ear, and then you came and talked to me, so I was like, oh, well, I'm never doing that again.
yeah, I'm like, and then somebody kept making the mannequin cry while I was thinking really loudly.
It's not my fault that they showed me where to do it.
It was like, oh, now I have to do what? I'm like, oh my goodness.
I know. I was up there with the group that's there today, starting that sim this morning. When all of them started crying, they're just like, "This is too much stimuli for this time in the morning." And I was like, "Sure is."
Welcome to my world.
I saw
Exactly.
that,
Welcome
and I
to
was
my
like,
world. You walk in and they're crying and screaming. They don't care what time it is. They don't care that it's shift change.
And you can't even ask them like what's wrong. You gotta
No.
figure it out.
Yeah, you gotta figure it out.
And be nice and be super friendly, upbeat.
Yes. And hold your composure and not freak out. Right?
Just welcome to
I
Turkey.
could not do it.
Yeah. Oh my gosh. Yeah. There was so much stimuli this morning. I had an argument with my son because he broke his Halloween costume already. It was crazy.
We're not in the same group for this.
Yeah, we're,
Well, yes, but we're on the same clinical group.
well, what medic are you doing?
Oh, it doesn't matter if you have the same.
I'm just asking what medic is doing.
Do you want to compare notes and do the same thing? So like you can do the same presentation that I do? Because if it's not on the same clinical data.
Are you getting stuck with what meds to work on?
I'm sorry.
She wants to work with me and copy my work. Like, you don't wanna work with her.
Most definitely. I didn't know the context of it.
I would like to copy yours too.
You know what?
So,
Never mind.
I apologize.
Hey, Peony.
if you are getting stuck with your medication presentations and you don't know what meds to work on, pull some from your head injury case study. Right? Here's some
Okay.
meds. Here's some meds right here.
We'll do the Johnson.
So from your head injury case study, you've got your amitriptyline, right? Why do we give amitriptyline?
Sorry.
No, you're good. Okay, so let's work through his past medical history first, right? So you're gonna do this if you haven't already done it in clinical. Has everyone gone through? Have you done this already?
Yes.
Okay, you're good. Okay, so you had your kiddo who has a history of irritable bowel, growth delay issues, acne, pediatric migraine, and asthma, right? So your amitriptyline is given for what?
Smooth stabilizer, but also active.
That one's for the migraines, right? Your ciproheptadine and hycosamine are given for what? Irritable bowel, right? Okay. Your tretinoin,
For acne.
that's your acne one, right? Your albuterol, I was gonna say, you better say asthma. Lactate, for his lactose allergy, right? What about his anastrozole? What's it do? What's its label use?
It's like breast cancer or something.
It's a breast cancer med. Why is he getting it?
Because of the growth delay issues, right?
Yes, so he's getting it for the growth delay issues, because what that med does in the body suppresses estrogen and increases testosterone, right? Okay, so if you haven't picked a med yet, these would be some good meds to do in your presentation. Okay, getting back to the lecture. Rye syndrome. What is Rye syndrome? How does it happen?
Aspirin, biosection when you take aspirin.
Yes, we think there is a very strong correlation of kids taking aspirin with a viral illness like the flu, right? And then they end up with brain swelling, they end up with liver dysfunction, right? So this is why it becomes a neuro issue with that brain swelling, right? So just like with your other conditions that cause ICP, you're going to see those things with Rye syndrome, right? That decreased level of consciousness, irritability, confusion. When you do labs, you're going to see that their liver function is off, right, and elevated. So really, prevention, right, is what we can do to prevent this from happening. So our biggest prevention piece is education on what? Not taking aspirin, right? And ideally in individuals less than 19 years of age, right? So we know that aspirin comes just by itself, right? What other common medications is aspirin in?
Like cold
Maybe. So they really have to watch the label, right, to make sure that aspirin isn't in it. Pepto-Bismol has aspirin in it.
Really?
Yes.
All of them?
I don't know if all of them, some of them do. So they really have to be careful in what they're taking, right? So that they don't accidentally take something that has it while they're also sick, right? Okay. So just like the other disorders that we talked about, symptomatic treatment, right? We're going to treat the symptoms. So if they're having ICP, doing those medication and those pharmacological and non-pharmacological interventions, monitoring liver function, right? We want to know what's going on there, and then making sure that you're monitoring your vital signs. Okay. Early recognition of this is going to get you to the most positive outcome, right? If we can recognize that this is what's going on, we've done that full intake history. We know what meds they were taking, if they were sick, right? And we know that if they took something with aspirin, it's likely leading to this. Okay. All right, let's talk about some neural tube defects. So these are pictures of some of the ones that I mentioned earlier. Okay. We are going to focus on spina bifida specifically. So these are just kind of there as like kind of a good to know, but I'm not going to test you on those. Spina bifida is what we're going to see. Okay. So you've got spina bifida occulta. This is your okay. This is your least affected kiddo, right? There's no real, really big defect. There's just like a hole in the vertebrae or the vertebral column where this disorder is taking place, right? But it's not really affecting the spinal cord itself. So a lot of times these kiddos they're not even diagnosed. Or they're diagnosed by chance because they were looking at something else and then found that they have this. So one of the things that you want to do on a newborn assessment is spread their cheeks and look in between the crease to see if you see a little divot or like a little pinhole. That is all you're going to see with spina bifida occulta, right? It's occultic. It's you can't really see it. Okay, and then you got meningocele. You can forget about this one. We're not doing this one. Meningocele. This is where the meninges protrude out from their back, but it's just CSF filled. It's the meninges and CSF. There is no spinal cord involvement. So these will have a little bit more of an affected, maybe some coordination sort of things, but not super extensive because their spinal column is still where it should be, right? It's still going through the spinal column. It's not protruding out, okay? What are they at risk for here? Rupture, absolutely. What happens if that sac ruptures? What else are they at risk for? Hmm? Far worse than meningitis. They're gonna have a herniation of the brain. So if that sac ruptures and CSF goes flowing out of there, that rapid decompression of that CSF is going to cause the brain to herniate down the brainstem and into the spinal column, ultimately leading to death. Okay. And then you've got your myelomeningocele. So this is the one that's most affected because you do have your spinal column out into that sac. So not only are the meninges out there full of CSF, but now your spinal cord is also out there, right? So you'll see that they have significant motor function issues below that, right? Below the level of effect where that defect is, okay? Most commonly, this is happening in the lower aspects of the spine, but it can happen really kind of anywhere, right? And the patho behind it, the primary defect is just an incomplete closure of that neural tube during embryonic development, right? As a result of lack of folic acid, right? Absolutely, okay? So some anatomical changes that we might see is that they might have an exposed spinal cord, meninges, and nerves at various spinal locations. So depending on where it is protruding is where you're going to see what's affected, right? And remember, wherever it's affected, it affects everything below it, right? Everything up above is gonna work just fine, but it's down below, okay? So, oftentimes where it's at is the lower spine, right? In the lumbar region. What do the nerves there innervate?
Your legs, your bowels, your
bladder.
Yeah, everything below there, right? So your bladder, your bowel, your legs, so they're gonna have coordination issues, they might not walk, they might have like a neurogenic bladder, right? So incontinence issues, things like that, okay? The severity depends on where it's at and what the condition is. Is it occulta, is it meningocele, or myelomeningocele, right?
Question. So those three are the ones we need to know, right?
Yes,
Okay.
yep. So the occulta, the meningocele, and the myelomeningocele, those three, okay? So again, we'll see mobility issues, bladder dysfunction, skin concerns. Which ones are you gonna see the skin concerns in the most, and why? The myelomeningocele, why? Due to their immobility, right? They can't feel anything, right? So yeah, they might not have feeling below there either, right? And so, you know, they might have wounds or sores that they're not, that they don't know about, pressure sores from being immobile and not having good position changes, right? They might have some cognitive effects, so learning disabilities, okay? Impacting their academic performance, their cognitive development, more so with our kiddos that have like the meningocele and the myelomeningocele. Okay. So how do we know that they have it? Well, the first thing we can do is a prenatal ultrasound. If they have a meningocele or myelomeningocele, are those going to show up on the ultrasound? Yes.
And don't they have
Will-
surgeries now? Intrauterine surgeries?
Yeah, I'm gonna actually show a video of it. It is really cool. So they can detect the meningocele or the myelomeningocele. The occulta, are they gonna be able to see that?
No.
No, because there's nothing protruding, right? But those other two, they have a sac that we can see on the ultrasound scan, right? So they should know as long as they were getting prenatal care. If they did the maternal AFP test, is it gonna show up on there? Yes, because that test is specific for neural tube defects, right? So they are going to be able to see if they have those issues there, okay? So with the AFP, You're gonna educate about the test timing and importance, explain the results clearly, and address the concerns, right? So, when do they normally get this? Between what?
10 and 15 weeks.
Between 10 and 15 weeks. So the lab work will show that they've got an elevated AFP, right? So we're gonna talk about that, explain the results clearly, send them for an ultrasound if they haven't already. We wanna know what's going on in there, right? And then the MRI, that's really gonna tell us the severity of the defect, right? And this will be after they come out, right? And have been born, we'll send them for that, okay? So how are we gonna treat it? Surgery, right? Absolutely. Because can we leave that meningeal sac just hanging out there? No, right? They need to go in, they need to close it because it has an increased risk for rupture, right? And if we rupture it, all the CSF moves out and then they can herniate their brain. So we're gonna go in and do surgery. They might often need physical therapy or occupational therapy, right? Depending on what that defect has prevented them or has decreased their ability to do, right? Help with their developmental challenges, improve their overall function, right, as best we can. And then we get to surgery. Let's take a look at it.
Fetal surgery for spina bifida is an incredibly complex procedure. At Children's Hospital of Philadelphia, where the surgery was developed, a team of more than 20 people are in the operating room. They include up to 4 fetal surgeons, 1 neurosurgeon, 2 anesthesiologists, a maternal fetal medicine specialist, a fetal cardiologist, and specialized nurses. They have performed this procedure more than any team in the world. Before surgery, the mother receives deep general anesthesia. Fetal surgeons make an incision across the mother's abdomen. The maternal fetal medicine specialist uses ultrasound to determine the position of the fetus and the margins of the placenta. The uterus is then opened with a specially designed uterine stapling device that controls bleeding, and the fetus is positioned so the spinal defect is visible. The fetal cardiologist monitors the baby's heart as the team closes the defect. The neurosurgeon removes the sac on the baby's back that covers the opening in the spinal cord. The sac is a thin membrane filled with fluid. The neurosurgeon and the fetal surgeon then close the defect in multiple layers using a lacing technique. First, the muscle layers are closed over the defect. Then the skin is closed over the muscle layers. This ensures a watertight closure. The mother's uterus is closed in multiple layers, then her abdomen is closed and she is returned to her room. The pregnancy then continues until planned delivery at 37 weeks gestation. Most often in our special delivery unit, created for moms carrying babies with birth defects.
She's got braces on her ankles. Isn't that awesome?
I'm assuming they do C-section
For mom?
when it's time for delivery.
Yeah, yeah, because they won't risk rupture during delivery. Yeah. Okay, so with spina bifida, whether it's occulta or the meningeal or the myelomeningeal, those 3 are absolutely preventable, right? Because we know that they are a direct result of a lack of folic acid, like we talked about. How can we prevent those from happening?
they're trying for a baby, making sure they're taking folic acid.
Absolutely. The recommendation is that any individual capable of becoming pregnant in their childbearing years should be on a folic acid supplement, whether they are actively trying or not. Because anything could happen, and unfortunate events like rape or something like that, it could happen, right? So any individual capable of becoming pregnant should be taking folic acid during their childbearing years, so that should they become pregnant, their risk of those neural tube defects is much lower, right?
Yes. Out of those three, is there any of them worse than the other one?
They progressively get worse. So spina bifida occulta, they might not have any issues at all. And the only way that they really ever find out that they have it is through, one, if we do a really good assessment at birth, right? And we see that like they have that little dimple, or they've got that little tuft of hair, which are kind of hallmark signs of occulta. But if that's overlooked, they really don't ever have any issues, and they only find it if they're investigating somebody else and they're like, hey, did you know you have this? Because they really don't present with anything. They don't generally have any mobility issues or cognitive issues or anything like that, because there's really nothing structurally wrong, right? And then your next one, meningocele, the spinal column is still where it should be. You just have the meninges that protruded with a sac of CSF. So they're slightly more at risk for some like cognitive issues or maybe coordination things, but not significant because the spinal column wasn't affected. And then your myelomeningocele, where the spinal column actually went out and is protruding into that sac, you're going to see that they've got significant like coordination and mobility issues. Yeah. So each one of them just gets progressively worse. Okay, let's talk about otitis media. What do you know about it? What is otitis media?
Inflammation of the middle part of the.
Inflammation of the middle part of the ear, right? This is an ear infection, okay? How do they get it?
Water in there.
Drinking their bottle.
Drinking the bottle laying down.
Okay, right, bottle propping, they got water in there.
If they have any other type of upper respiratory infection.
Yeah, if they've got an upper respiratory infection, right? Because those eustachian tubes just allow pathogens to move freely in between the ear and the nasal passages, right? So ear drainage just kind of drains through those and down into the throat, and we get rid of it there, right? Or into the nose, and then from there. So what's going on is that fluid is collecting in the middle ear and causing like muffled sounds or some hearing loss. Daycare exposes them to this, right? Because kids are cesspools of infection. Right? I told you I would continue to call them that. Hand hygiene, right? They're not good at it. They love sharing their germs. Okay, so they just get exposed to a lot more. So at daycare, or once they start going to like preschool, things like that. They're around kids. They love to share their viruses and bacteria. A previous episode does increase their likelihood of getting another one, right? It lowers that threshold. If they're exposed to like secondhand smoke, they're at greater risk for getting those. If they were breastfed, they have a lower risk of getting them. Kiddos who are formula fed are at higher risk of getting them. Like bottle propping, things like that, right? So when they come in and we're suspecting that they have otitis media, what are they going to present with when you're asking them about their signs and symptoms? Ear pain, pulling at their ear, yes, right? They're going to be pulling at it because it hurts, right? So those are kind of the biggest things, right? It's red. Pulling at it, they're irritable, right? They may or may not have a fever. They might have a history of nasal congestion. So if, you know, when you're asking them about their past medical history, were they recently sick? Do they have cough, congestion, runny nose, those sorts of things? Are they rubbing their eye? Because the eyes are connected to the ears through the cranial nerves, you may also see that they're rubbing their eyes if their ear hurts a lot, right? Headache, maybe. And then lethargy or behavioral changes, you might see irritability for sure, especially in our kiddos who can't tell you what's going on, right? All you can see is the behavioral things that they're doing, like they're rubbing their eye or pulling their ear, or they're just super irritable, right? So how do we know that they have one? So you're gonna look, right? You're gonna look in there, and you're gonna see that it is like full, and it's just like bulging, and the physician will tell you like it's full of fluid, right? Yes, there's an ear infection. Like the one that I had a couple of weeks ago when I went, and they looked in there, and like the doc like he barely put the thing in there and was like, "Whoa, you've got an ear infection." And I was like, really didn't feel as bad as he was making it sound. I just couldn't hear anything, but it wasn't painful. Okay. So how are we going to treat it? What do they need?
Antibiotics.
Antibiotics, absolutely. What do you need to educate about their antibiotic?
Take it till it's done.
Take it till it's done, right? They need the full course, because if we don't take the full course, what could happen? Okay, we could get antibiotic resistance. If we don't fully treat it, it could come back. They need to go, you know, go on another one, right? So we need the antibiotic. What else might they need? Pain relief, right? It hurts, right? The antibiotic is only going to kill the infection, but it's not initially going to take care of the pain, right? The pain will eventually go away as we start to kill the infection and that inflammation dies down. But they're going to need some pain meds up front, right? Okay. What if they get the ear infection before 6 months? What can they have? What can they not have? Not aspirin. No NSAIDs before 6 months, right? So no ibuprofen. We want them to take Tylenol or acetaminophen, right? Okay, good. All right. Strabismus. What is this? That was great. Okay, cross-eye, right? Or lazy eye is another term, right? Or wandering eye. Is this normal in kids?
Yes.
Until when?
6 months.
Until 6 months. Absolutely, right? It is absolutely normal. Until about 6, 7 months of age, right? It is normal. Beyond that, it is not normal, and so then we need to do some interventions, right? What might we need to do? Eye patching. Which eye are we going to patch?
Both of them.
Not both of them. The stronger eye, right? Because we want the weaker eye to work harder, right? Okay. So you got the definition of it is just a misalignment of the eyes, right? So whether it's like facing out or facing inwards. So you've got esotropia is an inward turning, exotropia is an outward turning, hypertropia is upwards, and hypotropia is down, right? Hyper up, hypo down, right? Eso in, exo, right? You're gonna exit, facing out, okay? Right? So the cause, nerve damage, we've got family history or genetic issues, or just weak muscles, right? Holy cow, they're loud out there. The symptoms, eye fatigue or strain, right? You might see that they're like squinting a lot to try to like focus their eyes. Double vision or blurred vision because their eyes aren't focusing on the same thing, right? One eye is going this way while one eye is going this way, right? Hard to see, hard to focus. So we've got some treatment options. So we talked about patching, right? So that's our least invasive. So we start with the least invasive things first, right? We don't automatically go to surgery. So we're gonna try those least invasive things first. If they don't work, then we'll take the next step. We'll progress towards surgery, or try to like do corrective glasses, right? So typically you'll see that these glasses like have much thicker lenses on them while they're trying to like get them to work, or they'll go in and they'll do a surgical intervention to realign those muscles, right? So biggest piece here is just early detection, right? Education on, you know, if the caregivers bring their kid in and they're like, man, my kid's got cross-eyed, but they're only like 4 months, proper education, right? It's normal until about 6 months. So right around the 6-month mark, we're looking to see like, did that go away or is it still pretty persistent? And then do we need to progress towards, now maybe we need to take a look at correcting it and giving them an eye patch, right? With the eye patch, when and how often do they wear it? What?
24 hours?
Do they need it while they're sleeping?
No.
No, right? While they're awake, right? Throughout the day. If they're sleeping, they can take it off. Okay? Let's talk about some foreign body. Kids love putting things where they don't belong.
What the heck is that?
That is a stiletto to the eyeball.
Oh my gosh.
Nice.
2 sisters were fighting over the high heels and bam, right in the eye. I don't know. I just really like it, so I just put that story up there. Right? They're fighting. They want the same shoes to, you know, prom or whatever. I don't know. But they got in a fight, and one of them got a stiletto to the eye.
When I was little, I stuck a beanbag bean up.
I used to do peas and carrots. Peas and carrots. I still hate peas to this day. But kids love to put things in all sorts of places, right? Whether it's in their nose or in their ear, accidentally in their eye, right? You don't like kids? Is that what you just said?
She said not only kids.
Oh, yes, not only kids. Not only kids, yes. Right.
We learned a little bit about that yesterday.
Yes. So, when they have a foreign body, let's talk about when they have a foreign body in the eye. What might they present with? Besides the stiletto actually hanging out of their face, right? Sometimes it's evident, sometimes it's not, right? It could be something from, you know, they were outside, they were playing in the playground, and they got a grain of sand in their eye, right? To they have a stiletto heel in their eye. So they could present with a lot.
Would something like that make them go unconscious?
Not necessarily. Yeah, not always. But they're gonna present with some signs and symptoms, right? Depends on what's in there.
Science said that you have a stiletto.
I know it
in your
is.
eye.
It's weird.
Something burning. Oh, yeah.
Somebody burned something. Who's on fire? Okay. So for those little tiny things that they're gonna have in there, right? They're gonna show up. It's gonna be red. It's gonna be irritated. They might be rubbing it. They might present with like some drainage, right? Like tears, because their eye is naturally trying to flush it out, right? But if they can't and they come in, what do we need to do? What's the first thing we do? Assess, right? The first thing we need to do is assess. What is going on, right? You're presenting with these things. Let's take a look. Let's do an assessment. What's in your eye, if there is anything in your eye, and go from there, right? And then depending on what it is, we're going to do some interventions, right? So if they present with the stiletto to the eye, it's pretty clear what your assessment is, right? It's there, they got a stiletto in the eye, now you need to do something about it, right? You need to stabilize. So you're gonna find all of the gauze rolls you can, and you're going to pack that shoe around their face, and then you're going to wrap it and hold it in place. until the surgeon can get there.
And then you're gonna put an eye patch on the other eye.
You also, yes, you do actually. Why would you want to also eye patch the other eye?
Cause you don't want any movements of the other eye.
Yes, because if they're moving one to look, are they gonna move the other? Yes, so you're gonna eye patch the other eye, right? So you're going to pretty much blind them while you're stabilizing, right? But what if it's a grain of sand? Just flush it, right? Absolutely. You're gonna grab a saline flush and you're just gonna pull down their lid, you know, so whether it's in the upper lid or the lower lid, you're gonna pull it down and you're gonna flush it out, right? If you need to, you can use like a wet contact applicator to kind of grab a hold of it and try to like work it out, right? So it really kind of just depends, you know, do your assessment first. What is it? What's causing it? And what can you do to get it out, right? Now, if they put it in their nose or their ear, you might not be able to get it out, but the physician will get it out, right? There are some medications, like so if they happen to put it up their nose, there are some medications that they can be given that expand the nasal passages to help it kind of come out a little bit easier. However, you could try to suction it out if you can see it, right? They might need to go in with like, depending on what it is, you might need to go in like with forceps and try to pull it out, right? Same with the ear. We don't really want to do that because we don't want to damage the ear, so we'll let the physician do that. With the nasal one though, there is some medication that they can give that expands it. However, it can cause them to get a little high and like hyperactive and become like slightly destructive. Personal experience, that happened to me when I was little. So it kind of just depends, right? What is the foreign body? What's there? Do your assessment, and then call the appropriate provider, right, to get it out, okay? Okay. All right, let's talk a little bit about congenital hip dysplasia, all right? Did you guys touch on this in OB? Ish, a little bit, okay. I think you maybe talked about it a little bit in like your newborn assessments when you were doing, right, where you had to do like the hip click sort of thing, right? So congenital hip dysplasia occurs when the hip joint doesn't properly develop during pregnancy and leads to instability of that joint, right? So when they're doing their assessment, you're gonna hear it kind of like pop and lock and click, and it doesn't form right and it doesn't sit right. So it's gonna cause, if left untreated, it's gonna cause some mobility issues later on in life, right? It affects about 1 in 1,000 newborns, more common in females, and can be inherited, right? Risk factors include breech position during pregnancy, family history of it, being a firstborn child. Huh? Firstborn girls, because you're firstborn and they're female, right? So puts them at 2 times the higher risk essentially, right, for having that. Good. Okay. So they have a shallow acetabulum, leads to joint instability, and impacts their development, right? So it affects how the hip joint grows and develops. So they're going to have issues with walking, walking, running, everything like that as they grow and develop. Okay. So how do we fix it?
Get a cute little brace. Hold them like this.
Like that, right? So you're going to see that they've got some leg discrepancy. If they're older and we're diagnosing it later than newborn, they'll have some delayed walking and a lot of pain. They will continuously talk about pain in that hip joint, right? So we treat it with a Pavlik harness, right? So this is the Pavlik harness, and we'll put it on infants under 6 months. So those who haven't really started to stand or really get around much. We can do a closed reduction, so a non-surgical procedure that aligns the hip joint usually done under anesthesia, and then an open reduction. So the closed reduction, again, is not a surgical procedure. They're just doing it and realigning things without having to open up the skin and tissue layers, where your open reduction is a surgical procedure and aligns everything the way that it should. And that is really for your more severe cases or the ones who are resistant to all of the other things that you've done, right? So a lot of our kiddos, the Pavlik harness works really, really well for them. What are some education points for parents of a kiddo who's in a Pavlik harness? It has to stay on 23 hours a day, right? So, you've got that 1 hour window. Does that mean that it's coming off every time you do a diaper change? No. It is designed for them to do the diaper changes without taking the harness off, right? Because the number of times they take it on and put it off, do they risk putting it on wrong? Yes. Can they adjust the straps themselves? They can, but they shouldn't, right? Who should adjust the straps? The physical therapist, the one kind of overseeing that piece of it. They're going to be the ones who adjust the straps. The parents are not to adjust the strap. They can, they will show them how to put it on and take it off without actually adjusting any of these straps, right? So it kind of, those will stay in place, but here where it secures to like the leg, those they can take off, right, and adjust, but those will stay. Yeah, and then the chest up here, absolutely, right? So that we know that it's exactly where it needs to be every single time, right? Now, are they gonna be given just one harness? Just one? They didn't give you multiple? Okay. Well, they should have a backup in case, they should have a backup in case one gets dirty, right? So say they have like a really bad like poop explosion and you get poop all over one, right? You should have, or they should have a backup in case that happens.
Throw it in that washer in that 1 hour you got.
Yeah, you got 1 hour if that happens, right?
I guess this is my 1 hour.
Okay. All right, so that is more, so that was a congenital one, right? They were born with that. There are some acquired mobility issues that they can come across, so like rickets, transient synovitis of the hip, injuries just resulting from like spinal cord injuries, right? This is just kind of more of a for your information, and that like we had to cover it, but I'm not going to test you on it. Okay. So there are some acquired ones. We're not really going to go into them much because we don't really see them much. Really, you're going to only see these acquired ones like the injuries if they have a spinal cord injury, right? So that's kind of a big one there. They will get these acquired neuro or muscular mobility issues if they have that, depending on how bad the spinal cord injury was, right, and where it was injured. Okay. Your rickets, your CSFE, your leg calf Raynaud's disease, these are more so like nutritional deficits, or your CSFE, your slipped capital femoral epiphysis, typically from overweight adolescents. So those who are carrying around a lot more weight will just kind of have a slip of that joint, right? And then that's pretty much it. Cool. Good to know. Not gonna test you on it. It's there. Cool. Don't dive too much into that. All right. Cerebral palsy. What can you tell me about cerebral palsy? How do they get it? Yes. What specific birth injury? A lack of oxygen, right? So an anoxic brain injury is what causes this, right? So it could be a nuchal cord, or maybe they have a prolapsed cord, or just some sort of compression of the cord that is preventing blood flow and oxygen to get to the fetus, right? So we can see that it's broken down into 4 main types. So your spastic, which is the most common, this is about 80% of cases. So they're just kind of, they're like that muscle twitching, right? They've got, like they just can't stop moving, right? They've got lots of muscle twitching. They're ataxic, so what does that mean? Their coordination is off, right? They have poor balance, so they're a huge fall risk, right? Your dyskinetic, those are pretty much bed bound, and they just kind of have this like writhing motion where they just can't stop moving in bed, which is slightly different than your spastic. The spastic is just involuntary movements, right? They could have epilepsy along with it, intellectual disabilities. So a lot of these kiddos will have some sort of cognitive deficit. They are not going to be at the developmental level of their age. Okay, they will have some of those delays. However, some of them just have minor coordination issues, but are able to function pretty well on their own. Right? So you've got a varying degree of how this affects them. In prenatal causes, we can see infections, maternal smoking, nutritional deficits, injuries, genetic factors, perinatal, so complications at birth, like we talked about, usually around compression of the cord in some way, or the cord is wrapped around their neck. And then postnatally, we can see from infections, seizures, hyperbilirubinemia. So these are all going to be just like in a short period right after birth. So it's either during the utero, right at birth, or shortly thereafter, right? It now can, if they have an anoxic brain injury later, they will still have some of these signs and symptoms, so it like will mimic cerebral palsy, but I don't know that they necessarily like classify it as cerebral palsy when they have like that anoxic brain injury as an adult. Okay. So what are they going to get? How are we going to treat this? Muscle relaxers, absolutely. One of the most common ones you're going to see is that they're going to be on baclofen, right? That helps with that spasticity. Side effects of that, though, are constipation, dizziness, headache, nausea, altered mental status, right? We could, some of these kiddos get Botox injections that also help with spasticity. Biggest thing there, injection site pain, right? Muscle weakness. They could then also get botulism, right, from the Botox. Anticonvulsants, so if their cerebral palsy also comes along with a seizure disorder, we're going to see that they're on those anticonvulsants. Right? So really, what is their effect of the disease or the disorder, and what signs and symptoms do they have along with it? Do they have additional things, and how are we going to treat those things? Okay. All right, so what are some complications in our kiddos with cerebral palsy? What are we going to see? Okay. Yeah. So we see that in our older patients, right? So they start to contract if they're not using their extremities, right? Why are we going to see some respiratory complications?
Increased secretion.
Okay. If they've got increased secretions, right? So some of those come with excessive drooling. What did you say?
They can swallow correctly.
Yeah, so if it's affecting their swallowing, right, it puts them at risk for aspiration, right? So if they've got swallowing difficulties. If they're immobile, what does immobility do to the body as far as respiratory system? Could put them at risk for pneumonia, right? Atelectasis, okay, those things. Nutritional deficits, so if they've got issues with feeding, are they gonna need some support? Yeah, right? So you might see that these kiddos have G-tube placements, right? So we're gonna feed them through a feeding tube, through their G-tube in their stomach, right? And then pressure ulcers. So if they're immobile, are they at higher risk for developing pressure ulcers? Absolutely. Feel pretty good with that? Okay. What can you tell me about scoliosis?
Isn't that maybe your spine?
Yeah, right? It's a lateral misalignment of the spine. So from side to side, right? How do we test for it? How do we know that they've got it?
Touch their toes and.
Yeah, have them bend over and you're gonna run your fingers along their spine, right? Do they go down in a straight line or do they go side to side as you go down, right? How do we treat scoliosis? Okay, least invasive first, right? So, first thing we need to know is what's the cause, right? So, a lot of them are idiopathic. We don't know, it just happens. Some of them are congenital, in that it is a hereditary thing. There's a family history of it, right? Or there's some other cause that we'll find, right? So we are going to put them in a brace first, right? If that works, great. But putting them in a brace does what? Okay, so it could put them at risk for skin integrity related to the brace and where it's touching them. If they're in the brace, are they engaging their core and their spinal muscles? So are they gonna have issues with that when the brace comes off? Yes, absolutely, right? So, talked about their assessments, their waistline imbalance, right? One side is gonna sit higher than the other, right? If they look like this, one side is higher than the other, right? It could cause cardiac issues, could cause respiratory issues. Why?
It's gonna move everything inside.
It's gonna move everything around, right? If you try to crunch yourself like this, does it kind of put pressure on your chest? Yeah. Now just imagine staying like that the whole time, right? It's gonna compress all of that and it's gonna put them in a weird position, right?
Like Shamar, you know
What?
You know that guy Shamar? I mean, he did everything.
I don't know Shamar.
And I think we need a little bit more.
Instagram, and he has.
Like, he was, yeah.
Oh, okay. I have not come across him. Not come across him. So, other than our initial, like, running our fingers along their spine, how do we diagnose it?
X-ray.
X-ray, right? That's gonna tell us initially what the curve of the spine looks like, right? Then we can do some MRI to rule out any other neurologic conditions. We can do a CT scan, right, to see exactly where it's at. We are going to just kind of observe them, right? If it's pretty mild, we're just gonna kind of observe them. Maybe they'll go to therapy, try to engage those, like isolate those certain muscle groups, right? To see if we can get those, one side stronger than the other to kind of pull it back. If it's not, if that's not working or it becomes more moderate or they have moderate to begin with, we'll brace them. And for severe ones, definitely surgery, right? That surgery is they're gonna go in, they're gonna open it up, and they are going to fuse their spine, right? So they're gonna have rods and pins everywhere, okay? So it is going to look something like. Okay, it's gonna look something like that. So they have a 37-degree curve up there, a 72-degree curve there, and a 36-degree curve there. So pretty significant. So we'll surgically correct those over 45 degrees. So that qualified, right? And so then they will go in and they will realign it and they'll put rods and pins in. Okay? This is a very extensive procedure. It's very invasive, it's very painful, right? It's got a very long recovery time. So these kiddos will, they'll typically have it done like at the end of the school year, like right at the beginning of summer. So they have all summer to recover before they go back to school in the fall, because it is that extensive of a recovery period, and they might not even be fully recovered by the time they go back to school. So they might need some accommodations when they do go back, right? These kiddos will oftentimes, so at least at Thunderbird, they are admitted to the PICU first for about a day after surgery, and then once their pain is like somewhat controlled and they've gotten them through that in first 24 hours, then they will come down to the med-surg floor and we'll finish up their initial recovery period there. So we'll have them for a couple of days before we send them home.
When I was doing my critical care clinicals, I had a 15-year-old girl that just had that. And she just had surgery and she was getting ready to discharge, and she'd been there about a week and a half.
Yeah, we have them about a week to a week and a half. Yep.
Yeah.
And each day,
She was at PCE for lots of it.
yeah, where at?
It was university.
Okay. Cause they don't have a, I wonder what they did there.
I don't know, but this is a 15-year-old girl. I had to go and do an assessment on her. Just a neuro assessment.
Wonder why they had it there, cause they don't have a Peds department.
I guess she was not big enough. They considered her, I think, no, I don't know. She's about a 120-pound, 15-year-old girl.
Yeah. That's weird, because I wonder if they had some
Maybe
some special thing, because typically if a hospital doesn't have like a Peds unit or aren't certified in a Peds unit, they can't admit there. So that's weird. For what?
Well, it was like, overdose.
So that's a little different.
Oh, okay.
Yes.
I thought it was a little weird to have a 15-year-old as my patient.
That is weird. That is not. So like a psych, like overdose sort of thing, like that's not unusual to go somewhere else, because typically we don't really like them with our like normal Peds population, and so that is not so weird. The spinal fusion at university is weird for a 15-year-old. Like that would have, usually is a Peds one, so either PCH or Banner, Thunderbird or Desert. So, yes, so they'll be there for about a week to a week and a half. Each day, they will have an order to progress their activity, right? So, like post-op day 1, it might just be get out of bed for breakfast. For day 2, it might be get out for breakfast and lunch, and then take a couple steps, right? Can you walk 5 steps, turn around, and come back? They will have a lot of pain control. They will have antispasmodics, right, like a muscle relaxer, because essentially they just got stretched, right? So depending on the severity of their curve, they straighten it out. Some of these kiddos grow like 2 to 3 inches without procedure, right? Depending on how bad their curve was. So now you stretched all of those muscles 2 to 3 inches. Are they gonna spasm? Yeah, think about when you've pulled a muscle, right? Because it hurts, it spasms a lot, right? It doesn't feel good. So then these kiddos will be on that as well. Okay. What do you need to watch for after surgery? Infection, right? Absolutely. Depending on how much of the spine, they are gonna have a huge incision, right? So you're gonna monitor for signs of infection, right?
Neural changes.
Neuro changes, absolutely, right? Because they open all that up. Anytime we break into the skin, right, we increase our infection risk. But for that specifically, we're going right into the spinal space, right? And so it creates even more risk.
Seeing how they're moving their feet and legs.
Yep, absolutely, right? So you're doing your neuro assessments, it's huge, like they just realign the spine. So did they damage the spine? So you wanna make sure that there's no damage there. Okay, good. All right, go ahead and take a break.
Little one.
I was just wondering for the dogs, if they listen to, I know on the book, it says like 4 hours, you can still give it, and then just get the next dose 12 hours later.
No, so not 12 hours later. So you're gonna, so if they have like a set, so say they give it at 7 and 7, right? And they miss that 7 a.m. dose, you have until 11 to give it. If they don't take it by 11, then we're gonna skip that dose, but they're still gonna take their next scheduled dose. So we're not gonna readjust the schedule to take it 12 hours later. They're still gonna take that next dose.
So even if we give it at like 10, I would still give it at 7 the next time.
Yes.
Oh,
Yeah,
okay.
so you're not gonna adjust their schedule at all. They're just gonna, you're gonna give it within that 4-hour window, and then they can still take their next scheduled dose when they're supposed to take it. That way you're not throwing them off that now they have to take it at 10 and 10 instead of 7 and 7.
Oh, okay,
Yeah.
yeah, that confused me a little bit, so.
Yeah, no, we're not gonna adjust their normal times. We'll just give that one if we can within the 4-hour window. If not, we're just gonna skip that dose and then they'll take the next one. If we can give it within that window, great.